Alright, so our next muscle, we've got the triceps brachii. So tri, obviously that means 3, and brachii is to do with the arm and moving the humerus. So it's 3-headed. It's going to be a little bit difficult to show the origin, but I can kind of describe it for you. So on the scapula, I'll show you an anterior view since it's kind of covering up our muscles right here. Right, this part of the scapula right here is the inferior tubercle. That's on the anterior side. That's where one of the heads of the tricep is originating, and the other heads are on the shaft of the humerus. And so, again, another example of an antagonist. If the bicep flexes, the tricep will go ahead and extend the arm. All right. Next is actually a smaller muscle. We're going to get into our muscles that move the scapula. This is the levator scapula. Levator, means to elevate, and that's exactly what it's going to do. So here's where this is. It originates right on the superior medial border of the scapula, and it's actually a long, thin muscle that's gonna run all the way up, and it's going to insert in the spinous processes of the cervical vertebrae, 1 through 4 actually. So that's the levator scapula. Another one is the rhomboid major and minor, and it's named after its shape. It looks like a rhomboid, quadrilateral in shape. So here's major. I've got these marked here. It actually inserts onto vertebrae 2, 3, 4, and 5, the spinous processes, which are sticking out towards you if you were looking at the back of the spine, and it is originating on the medial border of the scapula right here. So minor obviously is smaller, and it's right above it, so it's kind of a complex that goes together, and just superior to the rhomboid major, it inserts onto cervical vertebrae C7 and also thoracic vertebrae T1. Next, this is a big one. We're getting more superficial now. This is latissimus dorsi, rather known as our lats, dorsi meaning back, lateral to the side. So kind of wraps around our body a bit, and it's going to be right here. And something to mention about the latissimus dorsi is that it is a synergist with teres major, because what you're going to notice is that the latissimus inserts almost exactly where we can't see teres major anymore, but it inserts in the same place around the humerus on the anterior side on that bicipital groove, and it does a lot of functions. It will extend the humerus back. It's on the posterior part of the back, so horse is going to be extension. It's going to be a major adductor, so that will oppose the deltoid, which will adduct the arm, and it's a big medial rotator as well, because we can basically grab our hand around the humerus on that other side, and we're going to whip it this way, and so it's going to cause the humerus to immediately rotate or internally rotate. So if you know what the function is, then if you have a general sense of where it attaches, you're going to know why it attaches there and why it produces the movement that it does. Another big guy, trapezius, and it's got 3 portions to it, and you're going to see the way that the fibers run, why it does that. And it's important to look in the way that the fibers actually mesh and run together. So here it is. It's got multiple origins. It originates on the spine, and it actually originates on the superior occipital bone. The superior neutral line of the occipital bone, which is basically a bony prominence up on the back of the head, and it also originates here on the spine of the scapula. And so you'll see that these fibers here are more running in a superior direction, lateral direction, and inferior direction down here. And you could tell what's going to happen. These fibers right here are going to depress the scapula down. These fibers right here are going to depress the scapula up, and we have these middle fibers that can draw the scapula inward towards the spine. So it's a big muscle, and it's a big mover of the scapula. And then, of course, we need to put our deltoid back on, And we've gone completely superficial now. And so you can see the posterior aspect. And I think what I didn't mention in the first video is that the deltoid is named after a shape as well. If you're familiar with geography at all, it's named after delta. And a river delta, as it dumps water into a stream, it actually forms a triangular sort of, I don't know, a triangular sort of shape as the water runs through. And that's where it got its name. It's a deltoid. Now, there are some pathologies that I want to discuss. So we're going to go ahead and take care of all these muscles here. Put them off to the side. And let's look at this again. So let's make sense of some anatomy and some pathology in here as well. The first one I want to look at is the sick scapula. And so let's see if I can leave this here. So it stands for scapular malposition, mal meaning bad, so the scapula is not in its correct position. There's an inferior medial border prominence, so right here, here's the medial, here's inferior, there's a problem right here. It actually is a person who has rounded shoulders and almost a depressed, drooped scapula, and it actually sticks out and you can see it through the skin. And that's what they mean by that. There's coracoid pain, which we can't see the coracoid process, but remember that's on the other picture from this one, coracoid process right there. Can't see it on the posterior side, but there's pain reported there. And then dyskinesis of the scapular movement. So dys meaning not good, so we have dysfunction or not good movement, kinesis for movement of the scapula. So I'm going to demonstrate, first of all, dyskinesis with malposition. So it's going to look like this. It normally sits this way, but what's going to happen with a person with a sick scapula is that this is going to rotate. Their posture is going to look like this. So this is actually going to bulge out of the skin a little bit, and their shoulders are dropped. And as an overhead athlete, I'm going to take a perspective of an overhead athlete here, because that's one of the reasons why PT drew me into the medical profession. I want to really work with overhead athletes and prevent injuries. And this is one we see a lot. Rounded shoulders, a protracted scapula. It's moving in this direction rather than staying back, and that's gonna affect their performance and rehabilitation if they're injured, and possibly injury that they haven't had yet. So that's what it looks like. So as a therapist, we want to correct this. There can be a lot of problems. There can be some impingement down here because there's some nerves that run through, and I'll talk about another pathology right here. It's called the suprascapular notch. And if things get pinched in there, now we're messing with the muscles. But let's keep it on target here. So somebody with this situation is going to have a lot of pain, especially in the anterior coracoid process. We want to stop them from throwing right now, and we want to start implementing their stabilizer muscles and strengthening those up. So the supraspinatus, infraspinatus, that teres, we want to make sure that we can strengthen those muscles. And then we also need to work on their serratus anterior. Remember we showed that from the anterior view? It's starting here and on the medial border, and it inserts on those ribs 1 through 8. We need to strengthen that, as well as these rhomboids right here. Those rhomboids, we need to take this scapula and we need to retract it back. They're weak, and we need to work on that with those guys. And so that's kind of a very brief overview of a sick scapula. Let me show you another one. This one's called suprascapular neuropathy. And this one's a little bit harder for a therapist to find, because a lot of times with these shoulder injuries, there's more than one thing going on at the same time. And there's a problem with the suprascapular nerve. It looks like this. It originates from the brachial plexus, so I'm not showing the whole nerve and where it comes from, but it actually comes from nerve roots C, 4 and 5. There's a notch. You can see it, but it's blocked here by the spine of the scapula, and it runs through this little hole and then around and underneath here, and it's getting impinged. And a lot of times, people with sick scapulas have this issue. And so what it does, it cuts off this nerve's ability to innervate two muscles here, supraspinatus and infraspinatus. And a lot of the times when that nerve is malfunctioning, atrophy is occurring between these two major stabilizers rotator cuff, which isn't good. So they're actually going to feel pain right there at that suprascapular notch, and it's going to cause them dysfunction. So a lot of our overhead athletes may have some issues with this because as they're trying to stabilize their shoulder, pitching, volleyball spikers, they're going to start to overuse, and they're going to cause themselves even more problems. Even people just in regular day, painters and people like that. So what can we do? Well, one of the things we do with them is we start them off slow. We're going to have them up against a wall, a closed chain exercise, meaning limbs are not freely moving. A lot of times we can put a ball against the wall and they're going to roll it with a straight arm, and they're going to really be working on retracting that scapula and working on those muscles that affect the scapula that I mentioned earlier. Then we can progress them into wall push-ups or push-offs with both arms, and then eventually we want to start getting them on seated rows so they can really work on those rhomboids. So that's scapular neuropathy. Less common, but still